Hi, good afternoon and welcome. Thank you so much for joining us today. I'm Samantha. I'm the Director of Member and Partner Services for the Florida Association of ACOs. We're super excited for this opportunity to present to you our next installment of our webinar series, Heart Failure Management for PCPs, Treatment and Referral Options. Before we get started, I'd like to share a few quick notes to help make the most of your webinar. For audio, if you're already currently listening through your computer speakers, but you prefer to dial in by phone, simply click the small arrow next to the microphone icon in the bottom left corner of your Zoom window and select Switch to Phone Audio, and then follow the dial-in instructions provided. We welcome your questions and thoughts throughout our session. You can submit them at any time by clicking the Q&A icon on your Zoom toolbar. Just type your question there and we'll be collecting them along the way and addressing as many as we can during our Q&A portion. Feel free to use the chat box if you're having technical difficulties or just want to join in on the conversation. We're here to assist. With that, I'm going to turn our presentation over to Chris Abbott.
Oh, thank you, Samantha. Good afternoon, everyone. I'm Chris Abbott. I'm a member of the Board of Directors at Ventric Health and the Interim Chief Growth Officer. It's my pleasure this afternoon to be able to introduce our three panelists. Our first panelist is KellyAnn Light-McGroary, a physician and cardiologist. She is a heart failure and transplant cardiologist at the University of Iowa Health Center and the founder of KLM Healthcare Consulting. She's a longtime consultant and friend of Ventric Health. Jay Zdunik is a physician and family practice physician. He is the Senior Executive Medical Director at Agilon Health, where he supports value-based care, primary care organizations across the country. He is also the former Chief Medical Officer at Austin Regional Clinic. And finally, we have Eric Abel, a pharmacist and with an MBA. He is a clinical and commercial healthcare executive, founder of One Another Health, and he has deep experience with cardiac pharmacology and early diagnosis of cardiac disease. This webinar is sponsored by Ventric Health. Ventric Health's Viveo system is the only FDA-cleared Class II medical device that enables clinicians to non-invasively measure left ventricular end diastolic pressure, or LVEDP, the clinical hallmark of heart failure, in less than 5 minutes. With that, I'll hand it back to Samantha.
Awesome, thank you. Today's webinar is going to be a little bit different than we typically do. Ventric Health had a really good idea of kind of just bringing forth some of those, I think, top questions that are asked. So I'm going to go ahead and get started and ask a few questions to our panelists. If you find that you have additional questions, just go ahead and put them in the chat. So today we're going to start off with a question to Dr. Light-McGroary. Would you start us off with a quick review of the physiology involved with heart failure?
Absolutely. So I'm actually going to ask Chris to share our slides because I do think it's really helpful when you see this visually. So whenever I start talking about heart failure, I think the important thing to realize, and I think it's really pertinent when we're talking about stage B heart failure, is that heart failure is really the inability of the body to maintain adequate perfusion essentially to all its end organs to allow it to do what it needs to do physiologically, or it can only do it when it raises the intraventricular filling pressures. And so as we think about, and I hate to do this to folks, but a little bit of a trip back to cardiac physiology, I think it's a really good place to start because I think it helps make sense of this. When I talk to my patients in my heart failure clinic, I really try to help them understand the heart as a pump, and in many ways no different than a sump pump that's in the basement. If you are holding on to extra fluid in your basement and you need to get that out of there, you essentially set up a pump that draws fluid in, you have the pump that actually works, and then you have to push that fluid out of your house into your garden. That really is a good way to think about the way that the heart works. So cardiac output, how much blood comes out of the heart every minute, is really a function of heart rate times stroke volume. It's very simple. The key components of stroke volume really are the epitome of that pump idea. You have preload, the fluid that comes into the heart that essentially puts the stretch onto the heart muscle. Every muscle needs to have a load placed on it for it to contract back. So you want to make sure that you've got fluid returning to the heart during diastole and filling with venous blood to create that stretch. The next piece of that puzzle is the contractility. So what is the ability of the left ventricle, of the muscle of the heart, to eject blood? And how effective does that pump work? For example, is it thick because of somebody who's had longstanding high blood pressure? Do you have a patient who's had a myocardial infarction in the past and they've had death to some of their heart muscle? Have they had myocarditis? Lots of different things can play into the contractility or the actual function of that pump itself. And then when we start to think about that hose that goes out to your garden, the equivalent of that is what is the first things that the bloodstream sees as it leaves the heart. So that can represent aortic valvular stenosis. So if you have an aortic valve that doesn't open appropriately, that creates an obstruction to flow out of the heart and rises the afterload and the filling pressures in the heart. Just like if you step on that hose in the garden, if you create resistance to flow, you're going to put more stress and more strain onto that system and things are going to back up. In addition, and probably more commonly, having patients who have hypertension where they have increasing systemic vascular resistance in their aorta and their large arteries does something similar. It rises the afterload. It makes it harder for that ventricle to be able to get blood out of the heart. The important thing to realize is that in any given moment in a healthy individual, the heart adjusts all of these different variables in order to maintain adequate cardiac output. If I leave my office right now and have to run to the ICU, my body is going to create changes in all three of these areas. It's going to increase venous return back to my heart. It is going to increase the contractility of the heart itself, and my blood vessels will dilate so that I can get better flow out of my heart. The challenge for patients in heart failure is that with reduction in cardiac output, it's often due to impaired contractility or an increase of afterload. And so the heart really compensates by increasing preload through fluid retention and increasing that return back to the heart. So again, back to med school, nursing school, PA school, thinking about the Starling law of the heart. The greater the stretch on the heart cardiac muscle within physiologic limits, the better and the greater the force of contraction. But what you'll notice is that you hit a place where stroke volume can really only increase up to a certain amount because of the increasing preload. At some point, that switches from being helpful to being deleterious. It overwhelms that pump, and it is no longer an effective means to increase your cardiac output, and you actually start to see that decrease. So when we think about the physiology, it's really important way for us to think about what's actually happening and what are the best ways that we can really think about that and think about it in clinical practice. Chris, if you could just go to the next slide, because when we think, thank you. So let's just think about that statement in terms of rising left ventricular pressure, right? So you have that patient where they have not become symptomatic yet, but they are starting to rise up that preload, that increasing left ventricular and diastolic pressure, right? So as you have that increase in wall stress, you have that increase in preload and stretch on the heart, you will then start to see physiologic changes within the heart muscle itself. You'll start to see stretch of the annulus of the mitral valve, so you might see some leakiness of the valve. Their left atrial pressure starts to go up, and you'll start to see left atrial enlargement. As that happens, you increase your risks of things like atrial fibrillation, and then that pressure starts, because it's one continuous system, backing up into the pulmonary venous system and creating congestion and pulmonary hypertension. As the pressures go up inside the heart, you can have decreased coronary perfusion. It leads to some risk of subendocardial ischemia, and then the body kicks in with its very protective reflex. Our bodies, as you all know, are really good at keeping us safe from danger. And so when we are in immediate danger, we have a fight-flight response. We're walking across the street and a car comes at us. We release adrenaline. We activate our sympathetic nervous system so that we can either fight danger or run away from it. Something similar happens as all of these physiologic pieces start to happen. You start to see the same neurohormonal activation as a result of that in heart failure. But the body is not great at saying this is a problem on the outside or a problem on the inside. So that chronic neurohormonal activation then continues to lead to maladaptive remodeling. It's through this process that you will start to see the changes that we observe on EKG, on echocardiography. But I think the important piece is that very first box. It is that rising preload that sets off this cascade of chronic heart failure. Does that answer that for you, Samantha?
Wow.
I don't know if Jay or Eric, if there's anything else you'd want to add to that.
I think you covered it very well.
I think that was excellent.
I know I personally learned a lot off of that. Why is the left ventricle filling pressure such an important characteristic of heart failure?
You know, I think for sort of where I was going, it's sort of that initial compensatory response. If you think about a patient whose contractility has been negatively impacted, whether it's because their heart has gotten stiffer from chronic hypertension or they've had a myocardial infarction, they can't augment their contractility. So if you take a patient who is at rest, they might feel fine, but in order to exert themselves, in order to meet their demands, they have to start rising that left ventricular end diastolic pressure. And it's that first piece that sets off the cascade that leads to the physiologic changes that we observe, as well as the neurohormonal activation that happens.
Thank you for that. Did you want to add anything, Eric or Jay?
No, I would just,
Go
I
ahead,
was
Jay.
just going to say that I think that, again, that's a key point, and I think that the early rise in left ventricular end diastolic pressure is going to often predate any changes that you're going to see in structural abnormalities of the heart on echocardiogram. And so if we think about it, it really makes sense. I always explain it to patients this way. Like if you're going to go exercise and you're going to start to do weightlifting and you start doing bicep curls, how large your muscle gets is dependent upon how much time under tension it is. And if we think about the risk factors for heart disease, we start to think about those things that affect left ventricular end diastolic pressure, specifically afterload. And the primary one of that is hypertension. And so as we think about these patients who have had longstanding hypertension, it should not surprise us if we think about the fact that those patients are going to see a rise in their left ventricular end diastolic pressure before they ever get to structural abnormalities, because of the amount of time that their heart has been under tension of that increased blood pressure and working against increased resistance.
Yeah, absolutely. I think of just to add on to what Jay just mentioned and KellyAnn is you think of the heart doesn't really, we don't have an A1C per se, right? That tells us how, because the temporality of what's happening, just a short-term change in LVDP is natural compensation, but the long-term pieces of having that are what lead to the changes that Kelly just covered. If you think around like statistics and, around the population, if more than 50% of the US population has, uncontrolled hypertension or has hypertension, and only 20% of those are under what we would define as adequate control, that means that they are having that high afterload. They're having those and building those high levels of intracardiac pressures and LVEDP. That's going to lead to that remodeling. And so if you're trying to understand, if you check a blood pressure in the office, is that white coat hypertension or is it uncontrolled? How are they, what's happening in their day-to-day life? I just think of the LVEDP as being that key aspect that can give us that signal of how their body is adapting to those things, and maybe the signal, if it's out of bounds, that we have more than smoke here, we have a fire.
Very informative. Next question. One of the points of confusion that we often hear is that stage B heart failure isn't really heart failure. Can one of you walk us through the current staging of heart failure and tell us why identifying patients who are stage B is critical?
I can start us off. So the ACC, American Heart Association, Heart Failure Society of America, over the last decade, we've really tried to be more deliberate with our staging criteria. And part of it is to really help us identify earlier patients who are at risk to prevent the progression. The way I always think about the stages of heart failure is that it's a one-way trip down a single track. Heart failure is chronic progressive illness, and what we need to do is move up the identification earlier in the trip so that we can delay time between each of these stations. So when I think about these patients, a stage A patient is the patient at risk. So if you think about your clinic patients, you're thinking about those with diabetes, CKD, COPD, hypertension, obesity. Maybe they have a genetic component to it. Maybe they've been exposed to a cardiotoxic agent, like a cancer agent. But their hearts are structurally completely normal. Their biomarkers are normal, and they have never had a symptom. That is an important population because we want to make sure that every step of the way we're doing everything we can to optimize the treating of those underlying risk factors. Sometimes they are things that we can't always control, but it's that awareness so that we have that focus when we see them in clinic to make sure we're assessing it. Stage B heart failure, which I understand the confusion because in the guidelines it will say pre-heart failure, but really what it is asymptomatic heart failure, right? If we think about the definition of heart failure, and that's from Eugene Braunwald, sort of one of our fathers in cardiology, it's that idea that these are patients where that rise in LVEDP is leading to those structural and functional changes, but they're still on that part of the Starling curve where they haven't fallen off of it. So they're able to maintain their cardiac output in the setting of that rising LVEDP. This point, the patient has never had any symptoms or signs of heart failure, but this is truly a critical window for us to start our GDMT. I think the other key piece of it too, and I know Eric will talk more about the medications, is that the real advantage of a lot of our treatment strategies is they're not aimed at one single thing, right? We are using medications that have impact on their diabetes, on their hypertension, on their CKD, as well as on their heart failure. The next stage is when that patient, as we looked on that Starling curve, now they've fallen off and they can no longer maintain enough preload in order to increase the cardiac output, and we start to see it drop off. These are patients that now take that structural functional cardiac abnormalities and it transitions to signs and symptoms. Remember what I said, though, it's a one-way trip. So once a patient has become symptomatic, irrespective of whether or not you diurese them, you put them on GDMT, and they become asymptomatic, they will always remain at least stage C. The next stage then is probably most of my patient population, those really advanced heart failure patients. These are folks that have severe symptoms at rest or with very minimal exertion. They often have repeated hospitalizations. These are the patients that we see that we try to identify more advanced options, including ICDs, biventricular ICDs, whether or not they need mechanical circulatory support or consideration for transplant, as well as collaborating with good palliative care. So the question you asked after that, which is why is stage B so important? I think simply understanding that train metaphor is really the hallmark of it. We have to be able to slow that progression down that track. Prevention of symptomatic heart failure, meaning stage C, if we can intervene early, identify these patients, we can intervene with treatment, things like SGLT2 inhibitors, MRAs, better blood pressure control, helping with weight loss. All of those things can halt or slow the progression into symptomatic heart failure. We have data that shows that ACEs, ARBs, ARNIs, and beta blockers in stage B patients who have evidence of a decreased ejection fraction, that we see reductions in hospitalization and mortality. improvement in their risk of death. Statins blood pressure controls as well lower cardiovascular risk in patients who have known coronary disease as well as patients with LVH. So it again allows us to try to decrease the risk of coming into the hospital and their risk of death. The other thing that's really important when we think about that second slide where that rising LV-ADP drove those structural changes that lead to their symptoms, once that cardiac remodeling starts to progress with dilatation of the chambers, fibrosis of the tissue, reversing that damage is very, very difficult. Early pharmacologic intervention has been shown to prevent or slow these structural changes. And then finally, and I don't think it's something we can ignore, it really does help us to avoid the high cost of late-stage treatment. I think recognizing that if you think about patients over the age of 65, very, very high rates of having heart failure. Over 65% of patients present as their, defining or moment of diagnosis as an inpatient or an ER admission. That means that they have now progressed into stage C. They've gotten symptomatic. They are often harder to get onto medication. They have the costs associated with the hospitalization. As people progress into later stages of stage C and D, they have higher hospitalizations, more costly procedures that come with this intensive management. Stage B treatment is much more cost effective than having to manage advanced heart failure. And, full transparency, for many of our patients who get to the stage D, they may not have options like mechanical circulatory support or transplant. So it really is critical that we find these people early and make those changes. So
one comment I would make on that is
Yeah.
the key point about the prevention of stage C, or once they cross over that Starling curve and start to get dysfunction. I've been doing this for a long time. It's hard for me to imagine, but this is actually my 40th year in clinical practice. And one of my very earliest mentors, who was a cardiologist, one day pulled me aside and said, "Look, I know you made that diagnosis of that patient having an MI, and you think you're pretty hot stuff, but let me just tell you something. You didn't do jack squat for that patient. That patient has myocardial damage, and that's never going to be reversed." And he said to me, "If you're ever going to do anything for a patient, you got to prevent myocardial damage." And I never forgot that. And he had a very good example, and that was the example of the spring, as how it applies to the Starling principle, that if you take a spring and you stretch it, it'll snap back with a certain amount of force. And if you stretch it again, it'll snap back with a certain amount of force. But there comes a point in time where if you stretch a spring too far, it's sprung. It never snaps back. And his point was that that's what happens to myocardium when it starts to remodel. And so, I never forgot that. And then in 2001, when the ACC-AHA came out with their initial staging of heart failure guidelines, at that time I had a very busy fee-for-service practice with quite a few patients. The average age was about 57 and a half. I had 17 cardiologists in my practice, so everybody had an echocardiogram. And after that AHA, ACC guidelines came out in 2001, I stopped and looked at my practice. And what I recognized was that there was a significant number of patients who were coming into my office on a daily basis who I had attributed as being fat, out of shape, lazy, and non-exercising, who actually were symptomatic stage C heart failure patients. And it was a fundamental aha moment because it reminded me that 20 years earlier, this cardiologist said to me, "You haven't done jack squat. If you let somebody get myocardial damage, you've essentially not done your job." And I never forgot that from that point on, and really changed my way of looking at how I practice medicine for these patients. It used to be, did I want to have the argument with Mrs. Jones about, "Oh, your blood pressure is 138 over 88. I'm going to let it go for 3 months and see how it's doing." It really helped me get over my physician inertia about those borderline patients, or making the changes in the medication choice for these patients because there was a better choice to help prevent that. And if we fast forward 20 6 years now, right? We're now 2026. This is now the version whatever of the ACC/AHA guidelines revised. If you look at the incidence of heart failure, we haven't changed it one bit. And and the answer is because we have not paid attention to this. We have paid attention to all kinds of other things in medicine, but yet the number one thing that creates problems for our patients, heart disease, we have failed to do our duty as physicians and really become aggressive at moving the treatment of these patients upstream. And I think to me, it's an editorial comment of how we can get blinded by data and we can get blinded by a lot of other things, and we forget to do the fundamental things correctly, which is treat the risk of these patients.
100%.
That was eye-opening for myself. So I appreciate that, Jay and Kelly. And that was, I think for being, since presenting to the ACO network, that just, I think, resonates with so many. Truthfully, it kind of gave me chills just thinking about that, being able to present this information to our members and ultimately help, prevent exactly what you just said, Jay. So next question that I did have for you is, when primary care physicians suspect a patient has heart failure, their inclination is often to refer these patients to a cardiologist. Is there possibly a better approach? Are there options? What should the PCPs be doing, and how should they be involved in managing those patients?
Yeah, that's a
Jay,
great
I think
question.
this is kind of your topic, right? This is kind of where your expertise is.
Well, I don't know if it's my expertise, but certainly it's my passion. Um, it's a great question, and it's a great question for a variety of reasons. Part of that is that we have developed a mentality within healthcare that everybody needs a specialist when there's not really enough specialists to take care of everybody who potentially could need a specialist if we went down that route. Primary care is a position that really you've got to be really good at a lot of stuff. You just don't have to be an expert in everything. You just need to know where to go and where to start. And I think cardiology especially is one of those areas where it's really fairly simple because of the things that KellyAnn laid out in terms of the pathophysiology of heart failure. There's only four things you really need to think about. What's their preload, what's their afterload, what's their contractility, and what's their heart rate? And if you know what's abnormal, you start to treat those things which are abnormal with the drugs which affect those things that are abnormal, recognizing that as you bring those things back into normal, it's going to cause some compensatory changes elsewhere, and you just manage that. But the reality is that you're doing this every single day to begin with. You're treating somebody with blood pressure medicines who has blood pressure. Well, why are you treating them with blood pressure medicines? And the answer to that is because you want to prevent cardiac disease downstream. Well, that's the initial treatment for prevention of heart failure. So the concept for primary care is getting them to understand that this is really stage A, stage B, and early stage C heart failure is a primary care domain. It really is something that they should be able to handle in their office on a daily basis without question or without doubt about what they need to do, because it's pretty simple. The second part is that we now have guideline-directed medical therapy. And Eric's going to talk about guideline-directed medical therapy and putting patients on appropriate medications. When we first came out, I remember, I'm old enough to remember that when Captopril came out, it was a cardiology only drug initially. And then Carvedilol came out as a cardiac only drug. But the reality is these are drugs that need to be used by primary care on a regular basis because those are drugs that are going to make differences in patients' lives early on in the intervention of disease process. And convincing providers that that's what they need to do is critically important. And I spend probably half of my time with all of our partners having those exact discussions and trying to educate the providers that this is something that you can handle in the office. You don't need a cardiologist for this. You need a cardiologist downstream when they got more advanced stage C heart failure, when they've got stage D heart failure. That's when the cardiologists want to see them. So I think that it's a multifactorial process that causes this to happen. The other side is that, we live in a world, and we're here talking about ACO and value-based care, which I think helps to change the paradigm. But in a fee-for-service world, the mentality of a primary care doctor oftentimes is like, I don't have time to sit here and discuss heart failure with a patient. That's what the cardiologist is for. I got to see the next patient because there's an X number of patients I have to see in fee for service if I'm going to keep my doors open. I'm on an RVU model, or I'm on a whatever model it is for my compensation, and there's a certain amount of revenue that has to be generated to keep the business open. So I think there's a lot of things that kind of do that. And then the last thing is there's a lot of, untrue comments from media, et cetera, that, if you have this problem, you need to see a cardiologist for an issue. And I don't know that that's necessarily helping us do the right things for the patients, because nobody has a better relationship with that patient than their primary care doctor. And the primary care doctor should be able to have a discussion with that patient, a meaningful discussion with that patient that says, hey, this is what you have. You're not going to die from this. This is like being pre-diabetic. I'm going to tell you what to do so that you don't have to develop this. You're going to do what you need to do. We're going to watch us. If there's an issue where we think we need help, we're going to get you the help. And if we can have those discussions in our office, I think we are able to deliver a much better patient experience and actually get these patients to the appropriate level of care that they need.
Yeah.
That too, that, full transparency. I think about the clinic notes that I write, and, I go in there and I'm talking about my patient, whether it's HFpEF or HFrEF, but then I start to list out their comorbidities, their hypertension, their hyperlipidemia, their CKD, their diabetes. And inevitably, most of my comments around them are, this is the goals we need as per the PCP. And I think that's not an uncommon thing, that as PCPs, you are so much more effective at doing that holistic care that needs to happen for these patients, right? As cardiologists, we can get tunnel vision. And honestly, as well, too, cardiologists still struggle with stage B heart failure because we are more used to seeing those patients that are really symptomatic. Those are the ones that we really see because they show up at the hospital. Right. And so you all are actually better equipped, I think, than a lot of our my cardiology colleagues at providing that comprehensive holistic care of their underlying risk factors and being able to pivot on that relationship that you have with them to help them buy into the importance of treatment at this stage.
Yeah. I'll add in a couple of things. I mean, I think of the window of, if you just look at the data, the average lead time to get a patient into cardiology, I think nationally, is the last numbers I've seen were 33 days. So in primary care, the question is what can I do now to manage that patient? And what are the tools I have available? Getting somebody, getting a BNP. BNP has, I mean, any diagnostic test you have to think around not just what can it add, but what are the limitations of those? And I think that's one of the areas where, thinking of BNP, there's, some of those comorbidities lead to confounding outputs where maybe it's right, maybe it's wrong. Are there anything that actually, if the patient's obese, maybe it's actually falsely low. Patient may have something, or if I have CKD or diabetes, do those confound those outputs? And then echo is another one. I mean, echo is a staple, has been around for a long time. But there's so many different factors that come into that as to, when it comes into echo, there are, 60% of the cases, echo will miss catheter confirmed diastolic dysfunction or HFpEF. So that's, I'm thinking around those pieces. And that's just with a resting echo. If you try to improve the fidelity of the output there and move to a stress echo, maybe you improve that a little bit, but it still is not perfect. It's not the same as catheter confirmed diagnoses or validation. And then you move into some of the things where when it comes into LVEDP, if you look at the E to E prime, which is essentially the number you're looking there to kind of suggest what an LVEDP is, it doesn't really have good correlation with catheter directed assessment. And so those are some pieces there. And so, but at the end, heart failure is a hemodynamic disease. And so I think that's thinking around what are those tools that a primary care doc needs? Do they need to subtype it? Do they need to know that we have a problem and can I start therapy today? And what therapies can I start? And then it's also thinking around symptoms. How acute is this patient? Are they, how symptomatic are they? And they need to move in there. But I know KellyAnn will probably want to add into some of these things here, but I've spent, several years in this space where echo in itself is not like a lab test. It's not like looking at your BMP or your CBC where you get quantitative data and you can make an individual number there. There's a number of things that actually go into when you get an echo. There are patient factors that are going to influence how good of an image can I get. What's that canvas look like? And then there's also the equipment and the scanner. Of the device I'm using, not all of them are the same. They don't always have the same capabilities, from a point of care ultrasound to a high fidelity, high grade, large scanner. Can I optimize the gain to get a better picture of that window of the heart? And then it goes also into sonographer acquisition. I think the important thing to know is even in accredited imaging labs, about 15% of the images captured are not diagnostic quality. And then the next piece is there's going to be a variability in the reader. We're not perfect, even if you layer in AI on top of that to make it better. Those are things where it is a specialist tool. The specialists know the limitations. They know what you can get out of here, but there's also the bridge that goes after this. If you go to the next one, Chris, is the part of once I get the report back, you're going to get the essentially the impression of the reader and what they saw there, but there's also some pieces there that might be borderline, might actually signal early disease. Maybe it's normal at a high level based on ASE criteria, but they didn't actually understand the question you're asking. I'm asking whether this met the ACC definition of structural heart disease, and those are not completely aligned. But at the end of the day, it's those pieces where this is that bridge where you need an echo report, but it needs to be designed, or essentially, the PCP has to know what they're looking for, have to understand. And oftentimes those, the cliff notes of the report are not there with the distinction without a, really a trained eye. So I think it is a wonderful tool for the right case, right scenario, can characterize, further structural heart disease. But if the question is, do I have a problem, and when, do I need to first answer the question, do they have elevated filling pressures, and how do I need to react? Can I get them started on therapy? I think that's the part where the early diagnostics with, elevated filling pressures and LVEDP have a unique role, where you can almost democratize and figure out who needs to go on, with the symptom assessment, and figure out who needs cardiology, who can I manage today? Because it's not just who and what, it's also when, because we know that referral path. And, do I need to hit the stop button and send them to the ED, or do I need to get them into cardiology, when? And if they need an echo, great. But when do they need it? Do they need it in the next 12 months? Do they need it in the next month? Those are all directional things that should help guide action. I think this is a big one. Even Kelly can maybe speak specifically to this one. I think that stands out hugely.
I think what we have to remember is that any screening test is only as good as the population in that you're using it in. So you have to have a test that has good sensitivity, good specificity, and you have to be testing it in the right patient population. One of the things that we know is that biomarkers and echo as screening tools in those very early stages do not always perform well. And if you think about that initial slide where we started talking about what starts off the cascade, it really starts with that rising LV-EDP. In patients with HFpEF especially, those biomarkers like NT-proBNP, the echo parameters like E to E prime and the global strain, they can often miss in the very early stages. But what they are very good at is they often have good specificity. So if they're positive, they're helpful, but being negative does not necessarily help you. The advantage also too is the ease in understanding the report. To Eric's point earlier, if I as a cardiologist look at my echo report and I see, normal LV systolic function, no normal valvular function, but I don't look at the body of the report where I start to see, maybe there's rising in the LV-EDP through E to E prime, but maybe what I'm seeing is increasing left atrial enlargement and changes there. There will be sometimes subtle things that are captured in the body of the report, but the reader is not putting it together because in part there's a clinical diagnosis aspect of heart failure. But to Eric's point earlier, they're not reading it from that perspective of how do I meet the structural change criteria within ACC guidelines. If you look at the Vivio tool, for example, which is a non-invasive way to look at left ventricular end diastolic pressure, it's essentially what looks like a blood pressure cuff and a EKG electrode. It allows us to time off of the EKG, the cardiac cycle, and then using a series of inflations and holds of inflations on the left arm, we're able to mimic what we see in the cath lab with great fidelity when we match it up to each other. And with them, we have a specificity of about 83% and a sensitivity at 80%. In those early stage B stage B heart failure patients, you really don't have anything that hits that level of specificity. We may have similar sensitivity. We may have some similar specificity, but it's really about can we really get there?
And with the pragmatic tool also for the PCPs,
Yeah.
I mean, I think it's like the time and the burden is critical.
I think the takeaway point from this discussion is that there's a lot of tools that you can use to help diagnose heart failure. However, you have to want to diagnose heart failure. You have to want to make a difference for your patients. I think the fact that we have seen since 2001, when the ACC and AHA came out, that heart failure was the #1 admitting diagnosis and #1 readmitting diagnosis. And in 2026, if you take sepsis, that made up diagnosis out of the hospital away, heart failure still remains the #1 admitting diagnosis and the #1 readmitting diagnosis. We haven't done anything to change the curve here, right? But yet this is the one of the most costly diseases that we take care of in medicine, not simply in the terms of dollars, right? But also in terms of the morbidity and mortality that's associated with our patient population, the loss of quality of life, and from the standpoint of the ability of these patients to be able to do what they really want to do later in life when they should be enjoying themselves, not sitting around, being on oxygen, running back and forth to the hospital every single time. And sometimes a story actually helps to really solidify this and drive home the point. And I have a personal story on this that is rather sad, but it really emphasizes the physician inertia that exists in terms of this diagnosis. My mother-in-law came to visit me for Thanksgiving last year, and she delayed her trip by a week because she had to have her AWV done, her annual wellness visit done by her PCP. So she had it done. She came to see me and she got here and she was here like less than 24 hours. And I noticed that she was really short of breath when she was going up and down the steps. And then she said it was nothing. She was just tired, etc. And the next day she came down the steps and she literally had to grab onto a chair because she couldn't move. She was short of breath. And I was like, well, this is kind of ridiculous. You're really short of breath. You can't do anything. I'm going to see you in the office and we're going to see what's going on. Fortunately, the where she was being treated had Epic. I had Epic in my office, so I was able to pull up all of her medical records from Care Everywhere. And when I did, I found out that she had had two echoes done 4 and 5 years ago. And both of those echoes at the time that they were done showed that she had evidence of structural abnormalities that would constitute stage B heart failure at that time. Well, now she's clearly got symptoms and she's got, you know, what at least presumptively would be stage C heart failure. So I repeated her echocardiogram because it had been 4 years. She had a bicuspid valve. She had left atrial enlargement. She had significant left ventricular hypertrophy. She had septal enlargement. And I repeated the echo, and now she had wall motion abnormalities, suggestive of probably underlying coronary disease and some other things. So, make a long story short, she ends up getting a cath back in Pittsburgh where she lives. Her cath physician came out and said everything looks fine. There's no blockage of the arteries. And I said, well, what about her LVEDP? I said, that's fine too. I said, well, how do you explain the echocardiogram? Well, it's nothing. She's got no abnormalities. Her cardiologist was resistant about putting her on a diuretic, putting her on SGLT. So a couple months go by, and recently, just a month ago, she's in need of a hip replacement. So she has to go in and get checked out. She's really short of breath now. They repeat her echo. Her EF had gone from 48% down to 35% now. She's got even more progressive enlargement of her heart and more dilation of her left atrium. So, make a long story short, I'm standing in the ICU, or sorry, in the cardiac cath lab, arguing with the cardiologist about why this woman probably should be on an SGLT and a mineralocorticoid inhibitor and some of the other drugs that are part of guideline-directed medical therapy. And he's looking at me like, well, I'm the cardiologist. Why aren't you listening to what I'm saying? Because you're not doing what you're supposed to be doing. Like sometimes we have to advocate for our patient population. And as a primary care doctor, that is what you should be doing. You should be advocating for your patient population because you're the one they're coming in to trust. And they're saying, hey, I don't feel good. Tell me why. And when things don't make sense, there's a reason why they don't make sense. So we have a lot of tools and a lot of techniques, but the first thing is you have to have suspicion and you have to have a willingness to explore and find this condition if we're going to change the paradigm that exists today. I'll get off my soapbox.
100%.
No, it was great to hear, Jay. I think sometimes that's a way for people to correlate how to take it back and present it, to their patients. We did have one last question that I really wanted to touch on because I think it's important. Eric, this is kind of tailored for you. So one of the most positive aspects of heart failure treatment is that we have some highly effective medications. Given your experience as a cardiac pharmacist, do physicians work through the process of getting patients on the full GDMT program? And can you kind of just walk us through that?
Absolutely. Chris, do you mind bringing up a couple slides there to help? I think some of the inertia that Jay and KellyAnn mentioned also with the stage B also touches here too, right? It's historically we didn't have a lot of great things, to offer a stage B patient. And that has changed. The evidence has changed. And I think that's really thinking around at a primary care level, what is it that it can do? If I do a test and I diagnose, stage B or even early stage C, yes, I'm treating the hypertension, but am I treating it to goal? Should they be on, one of the MRAs, spironolactone, eplerenone, now finerenone too? Those are things that I think you think out there, but it's the one that really stands out to me is the SGLT2 inhibitors, where you have a large population with a number, you see that the check boxes at the top as whether it's CKD type 2, obesity, hypertension, ASCVD, those all are going to lean in as to, the question is not why should I put them on there, but the question is more the inverse of why shouldn't I? And if you only have about 10% penetration of the market for eligible populations, then you have to beg the question is like, what do we need to do there? Is it I'm not familiar with the drug, what it does. Are there utilization management barriers, in terms of getting somebody authorized to be and covered on the agent? What do I need to look for? Are there patient factors? They're saying I'm not sure I want a new drug. But I think that is the one that I think that should be pushed on probably the most at this level, because at the point in time where if I were to do, I get elevated filling pressures or I have other signals, whether it's echo or whether it's Vivio, whether it's a BNP, it's where do I start, right? If I have them, the hypertension, they have them on an ACE or an ARB. If they're not, they should be on one. We should be pushing those and maximizing doses. The next drug on there right now is the SGLT2 inhibitors. And I think that it's really trying to lean in on those and really get those started. Beyond that, it's the next flavor is going to be into the MRAs. There's only one drug that has really a FDA approved indication for HFpEF, and that is finerenone. That being said, it's also really almost cost prohibitive at this point. So you've got to, a lot of times the primary care docs and the cardiologist will start with spironolactone as an option there. There is some monitoring, but I think that's the really important thing is if I start an SGLT2 inhibitor versus some of the others, SGLT2 inhibitors, the initial dose and the target dose are the same. There's not really titration, right? And I think that's an important aspect. But the other pieces are, as I get them started on the ACEs and the ARBs and the MRA, at what it's not Ron Popeil, set it and forget it. It's really that piece to work together to move towards a goal dose in therapy and titrate. And it's titrating as frequently as every couple of weeks or at least every month to get to that goal dose and monitor accordingly. The last piece there, that if you're in early diagnosis, you may not know where the beta blocker fits yet unless they had a preceding condition. So GDMT is at least thinking of the first, 3 drugs. Is it an SGLT2 inhibitor, an MRA, and an ACE or an ARB? That's really the starting point. The evolution is as you understand more around the patient's type of heart failure. Do they have HFpEF or HFrEF? That's when you start thinking and as the progression, the symptom burden comes in as to where do the others fit. And weight management is one of those pieces that I think the data is early, but I think managing the obesity is really one of those fundamental threads that lives below. If you're in stage A and they're moving into stage B, that's one of those conditions you need to keep on top of your radar. Anything else to add to that, KellyAnn or Jay? I think the next slide I'll cover as we kind of wrap up is one of the biggest things that I think is the economics. And this is where as pharmacist also working, having worked with the cardiologist, the primary care docs, and having spent time on the payer side, I think of the patient first. And it's like, you think about the payer economics, what's the cost to the payer? Much cheaper to be on in aggregate of GDMP when you look at this versus a hospital admission. But the other side is the patient. What's the out of pocket to the patient, and how are they going to be able to cover this? In an ACO, the questions are, you're taking Part D risk or not? At the end of the day, it's trying to make sure that I'm supporting the patient in the right way to manage, really total cost of care and the right thing for the patient. And I think those are the really important pieces to think around as to the monthly out-of-pocket or annual out-of-pocket of being on GDMT, what's that look like? And so, this being said, this is a snapshot in time and representative. It is not exactly what it is today because drug prices change, they're dynamic. But I think it's really important thing to think about. There are things happening. The Inflation Reduction Act, in the Medicare population has really opened up the doors for some of the agents to bring those in at lower costs. Some of those are moving into generic phases in the next few years. So I think it's really important it's not why should I, it's also why shouldn't I, and the balancing of the prima non nocere. Like, where do I catch them in the first do no harm. Making no decision is always a decision, but there is, I think the thing is, if I have a signal of where they are in the diagnostics, what's the right diagnostic that helps me make a decision for this patient today? And then what's the next path beyond that? It's really, how do I start them on some level of GDMT? And depending on where you catch them, that isn't 4 drugs. That's not 4 pillars. It may be we're starting with 2, and maybe it's 3. So I think that's an important balance to consider.
Thank you for that, Eric. Before we conclude, is there any last thoughts that you would want to share, KellyAnn, Eric, or Jay, before we conclude for the day?
I think I would just reiterate that you have an opportunity that most cardiologists don't have, and that's to really act early and keep these folks from ending up in a clinic like mine. I live both, I work every day with heart failure, but I live in a family of heart failure as well. And so I've seen both sides of it. And anything that we can do to engage early, educate our patients, get them on the appropriate medications, you will have a significant impact on their longevity, but also their quality of life. And that's really what this comes down to, is how do we prevent them from developing the sequela of heart failure, which is often irreversible and such a burden to patients and families. But thank you. Jay?
I would just echo what you just said. I think you summed it up perfectly. We have to choose to act.
Amen.
Well, I thank all of you, Chris included, for taking the time out today to talk to us more about heart failure and what our physicians can do from the ACO standpoint, and really kind of, I think, taking that step and fully, one of the takeaways is you don't necessarily have to refer out. Try to keep it in-house and manage the symptoms there. And, I think from an ACO standpoint, that's very important. It does help keep those costs down. So again, thank you all for your time today. Truly appreciate it. I know I learned a lot, and I hope all of you that joined us did as well. With that, we hope you have a great day, and we'll be sharing this information afterwards. Thank you.
Thank you.
you.
Thanks, everybody.
Have a great day.